Welcome, everyone, and thank you for joining us this evening. My name is Lily Banning, and I am the Community Impact Director here at the American Heart Association in Oregon and Southwest Washington. The American Heart Association and Hillsborough Medical Center have joined forces to reduce blood pressure outcomes and increase education right here in our community. 1 in 2 Americans have high blood pressure, and 75% of those do not have it under control. In Oregon, 32% of people have been diagnosed with hypertension. So we know that hypertension disproportionately impacts communities of color, and we see that nationally. Black men and women have higher rates, nearly 58% of hypertension, and Latinx individuals have a control rate of only 17%. So that is why we're here today for this discussion. A couple of housekeeping items before we begin. Today's discussion is in a webinar format, and even though we cannot see you, we want to hear from you. We will have time at the end of each session for our audience Q&A. So please remember to put your questions in the chat box and make sure that you choose everyone from the drop-down menu. And as a reminder, today's webinar is eligible for continuing education credits. You can go to learn.heart.org to claim those credits. So now it is my pleasure to introduce Dr. Nandita Gupta, the Medical Director of Cardiovascular Services at OHSU Health Hillsborough Medical Center. She is board certified in internal medicine, general cardiology, echocardiography, and nuclear cardiology. She is an experienced cardiologist with a special interest in heart failure and heart disease in women. And she also sits on our local board of directors for the American Heart Association of Oregon and Southwest Washington. Take it away, Dr. Gupta.
Thank you so much, Lily. Good evening. A hearty welcome to all of you. So as Lily shared, for our webinar session today, we chose to talk about hypertension and its impact on heart health. Despite all the advances in science, 1 in 2 Americans suffers from hypertension. And unfortunately, 75% of adults with hypertension do not have it under control. It is the leading cause of morbidity and mortality. It is second only to cigarette smoking as a preventable cause of death. Now, recognizing its asymptomatic nature, it has often been called as the silent killer. In Oregon, nearly 30% of adults suffer from hypertension, and the numbers vary by race, age, and gender, as highlighted in these slides to follow. Next slide, please. So as shown in these slides here, 30% of the Oregonians reported high blood pressure, 27.3% of women, and 33% of men. Hypertension was the second leading cause of death in Oregon, and lower income adults are over 12% more likely to have hypertension than those in the higher income brackets. Next slide, please. Here we see the age-adjusted risk of hypertension, which varies by race, predominantly impacting the African American and the American Indian and Alaskan Native populations. Now, Target Blood Pressure is a national initiative formed by the American Heart Association in partnership with the American Medical Association in response to the high prevalence of uncontrolled blood pressure. To discuss this important topic today, we have 3 wonderful presentations. We'll begin a presentation on the importance of hypertension and its cardiovascular impact. This will be followed by a conversation on racial disparities and how they affect blood pressure management. And then lastly, we will have a conversation on leveraging diverse population care for hypertension in a team-based approach. So I'll start off with saying a big thank you to our team here with American Heart Association and Hillsborough Medical Center, and all our speakers from Virginia Garcia, ISALUDE, Pacific University for today's event. I'd like to now introduce our moderator for the day, Dr. Joe Hardman, Chief Medical Officer of OHSU Health, Hillsborough Medical Center. Dr. Hardman has worked at OHSU for over 14 years, previously serving as an Associate Residency Program Director for Internal Medicine Residency Program, Medical Director of the Internal Medicine Practice at OHSU, and Medical Director of Clinical Integration. He continues to practice as a primary care general internist at OHSU, where he advocates for a well-rounded approach to health. including combining lifestyle change with medical interventions to help his patients meet their personal healthcare goals. Dr. Hartman, thank you so much for taking time out of your busy schedule to moderate our session today, and it is our true pleasure to have you leading us in this important conversation.
Oh, thank you so much, Dr. Gupta. I'm really excited to be here today for what promises to be a really informative session. I say we just go ahead and kick off our first presentation. We'll be discussing the diagnosis of hypertension, reviewing the guidelines, and discussing how blood pressure impacts cardiovascular health. So let's get started.
Thank you, Dr. Hartman. So I would like to start us off by talking about the 2017 American College of Cardiology, American Heart Association guidelines for prevention, detection, evaluation, and management of high blood pressure in adults. These guidelines were released in 2017, and they provide the evidence-based approach to reduce cardiovascular risk through lowering blood pressure. Now, while we have many national and international guidelines, these particular set of guidelines are the basis of our clinical practice in cardiovascular medicine. These guidelines were a culmination of partnership between American Heart Association, American College of Cardiology, and 9 other professional societies. A 21-member panel of multidisciplinary experts involving physicians, nurses, pharmacists, and patient representatives helped develop these guidelines. And most importantly, there were no industry relationships involved. Now, while these guidelines were very comprehensive, I feel like they answered 5 key questions. And I hope in my next 15 minutes of presentation, I can walk you through these 5 important questions. So the first question was classification of blood pressure. These guidelines fundamentally answered the question of what level of blood pressure should be considered normal versus abnormal. They highlighted the importance of home blood pressure monitoring in addition to office blood pressure measurements. They also looked at the importance of screening for secondary hypertension in patients who are diagnosed with high blood pressure. They make some specific recommendations on treatment for hypertension. And lastly, they highlight the importance of cardiovascular benefit or cardiovascular adverse effects from uncontrolled hypertension. So, in these guidelines, although the definition of the normal blood pressure remains the same as the JNC7 guidelines, so average systolic blood pressure of 120, average diastolic blood pressure of 80, these guidelines replace the term prehypertension with elevated systolic blood pressure and stage 1 hypertension. So the upper end of prehypertension gets reclassified in these guidelines as stage 1 hypertension. This is because adults with blood pressure in this range have an approximately 2-fold increase in risk of cardiovascular disease compared to adults with normal blood pressure. And some of the recent randomized controlled trials have demonstrated the benefit of a systolic blood pressure less than 130. Now, this change in blood pressure classification is estimated to result in an increase of about 14% in the prevalence of hypertension in the United States. But it only increases about 1.9% in adults requiring antihypertensive drug therapy. And this difference is accounted for by role of non-pharmacological therapies or lifestyle changes. And I will talk about them a little bit more further down in this presentation. Now, the guidelines also urge clinicians to obtain accurate measurements of the blood pressure. Next slide, please. And they base their estimate blood pressure on average of 2 readings, at least on 2 separate occasions. The guidelines also recommend greater use of out-of-office blood pressure measurement to confirm the diagnosis of hypertension and titrate medications. Now, the importance of the out-of-office blood pressure measurement comes from recognition of white coat syndrome or white coat hypertension and masked hypertension. So as I shared with you earlier, in terms of confirming sustained hypertension, elevated office and out-of-office readings are both equally important because diagnosis of sustained hypertension attributes higher risk of cardiovascular disease in adults compared to those with normal blood pressure. White coat hypertension is when there is office hypertension, but it is not confirmed by an out-of-office blood pressure reading. This is present in about 10 to 25% of adults with office hypertension, and their cardiovascular risk profile tends to mirror more with those of normal blood pressure. And most importantly, these adults may not require any treatment. On the flip side of this is masked hypertension. Masked hypertension is when the office blood pressure reading is normal, but out of office blood pressure is high enough to be in the hypertensive range. This is present in about 10 to 25% of adults again, and importantly, their cardiovascular risk profile is similar to adults with sustained hypertension. These are the patients that should be considered for antihypertensive therapy. Now, the guidelines also lay a lot of emphasis on how the blood pressure should be measured. So they have very specific instructions in terms of preparing the patient, make sure the patient is sitting in a relaxed position, in a chair with feet planted on the ground, back support, avoid all excess stimulants such as caffeine, exercise, and smoking for at least 30 minutes prior to blood pressure measurement. Ensure the bladder is empty. It's an important aspect that we often overlook. And then no talking during the rest period or the period of measurement, and then removing clothing so that there is good contact between the cuff and the skin, and measuring while patient is lying down or sitting, but without adequate positioning and may not give us a reliable reading. The guidelines also talk about using a validated blood pressure measurement device, make sure that the patient's arm is supported. The position of the cuff is in the middle of the upper arm, aligned with the mid-axillary position, using the correct cuff size, and then using a stethoscope for manual recordings. The guidelines also talk about that at the first visit, you should check blood pressure in both arms, and then as subsequent readings would depend upon the higher blood pressure on whichever arm it is, and 2 separate readings should be done about 1 to 2 minutes apart. The guidelines also talk about documenting the blood pressure appropriately, and then, as I mentioned earlier, use an average of 2 readings obtained on 2 occasions to estimate a level of blood pressure. Lastly, the guidelines also talk about how it's important to share your observations and your findings with the patient in a written and a verbal format. Now, when we are talking about high blood pressure, we also want to make sure that we talk about secondary hypertension or secondary causes of high blood pressure. Individuals in whom we should be careful to screen for secondary hypertension are those who have drug-resistant or drug-induced hypertension, when there is abrupt onset of hypertension, when the onset of hypertension is in young patients, so particularly those under the age of 30, when otherwise previously controlled blood pressure suddenly starts creeping up or suddenly increases, when you see target organ damage, such as damage to the kidneys or to the eyes, disproportionate to the level of blood pressure. Accelerated or malignant hypertension. Accelerated hypertension is sudden, severe increase in blood pressure resulting in target organ damage. Malignant hypertension is a hypertensive emergency with systolic blood pressures as high as 180 to 200. Onset of diastolic hypertension in older adults, meaning those above the age of 65, and unprovoked or excessive hypokalemia. Some of the commonest causes of secondary hypertension are renal parenchymal disease, renovascular disease, primary aldosteronism, obstructive sleep apnea, and drug or alcohol induced. Now, some of the uncommon causes I've highlighted here are pheochromocytoma, Cushing's disease, hypothyroidism, hyperthyroidism, coarctation of aorta, primary hypoparathyroidism, congenital adrenal hyperplasia, and mineralocorticoid excess syndromes other than primary aldosteronism. It is important to recognize that 10% of all hypertension patients may have secondary hypertensions, and correction of secondary hypertension may fix the problem. So it may make the blood pressure go back in the normal range. So it is important to recognize and look for these and treat these numbers. In terms of diagnostic tests for patients when you diagnose them with high blood pressure, some of the basic tests are checking for fasting blood glucose, complete blood count, lipid panel, serum creatinine, serum sodium, potassium, calcium, TSH, urine analysis, and an EKG. Optional testing would include things like an echocardiogram of the heart, a uric acid, urinary albumin and creatinine ratio, and additional testing as guided by a suspicion for secondary hypertension based upon the diagnoses that I spoke about earlier. Now, in terms of the treatment options, so once the diagnosis has been made and workup has been done, the treatment options are lifestyle changes alone are recommended for most adults with newly classified hypertension of stage 1, so systolic blood pressure of 130 to 139, diastolic blood pressure of 80 to 89. Lifestyle changes plus drug therapy are recommended for those with existing cardiovascular disease or increased cardiovascular disease. Increased cardiovascular disease risk is defined an ASCVD risk of greater than 10% in 10 years, patients with diabetes or patients with chronic kidney disease, or in older adults above the age of 65. Treatment is also recommended with pharmacological therapy for all individuals with a systolic blood pressure more than 140 or a diastolic blood pressure more than 90. Now, after initiation of antihypertensive drugs, regardless of the ASCVD risk, the recommended blood pressure target is less than 130/80. So that's an important number to remember, 130/80. Now, in terms of choice of medications, there are some differences, but general similarities in the efficacy and safety of drugs which are considered first line. So lowering blood pressure becomes more important than the choice of drugs, except in the presence of compelling indications. So compelling indications are conditions such as heart failure, ischemic heart disease, post-myocardial infarction, where choice of certain medications has been shown to prolong survival compared to other medications. In the absence of compelling indications, diuretics or calcium channel blockers are a good first choice. Drug classes that are generally considered an acceptable first-line therapy are diuretics, calcium channel blockers, ACE inhibitors, and angiotensin receptor blockers. Now, in terms of choices of drug therapy, combination therapy is often indicated with initial therapy of 2 drugs in most people, especially in Blacks or in adults with stage 2 hypertension, meaning systolic blood pressure more than 20 millimeters of mercury and diastolic blood pressure more than 10 millimeters above target. Again, certain best practices in terms of choice of therapies are use agents with complementary modes of action, such as diuretics or calcium channel blockers with an ACE inhibitor or an ARB. Use combination pills when feasible to reduce the pill burden on the patient. In Blacks with hypertension, but without chronic kidney disease, initial therapy should include thiazide diuretics. Guidelines also caution us that simultaneous use of ACE inhibitors and ARBs is not indicated and could be potentially harmful. Now, in terms of non-pharmacological therapies, it is very important to recognize the role of non-pharmacological therapies, particularly in patients with stage 1 hypertension who have low cardiovascular risk. Importance of weight loss. So every 1 kilo drop in weight reduces systolic blood pressure by 1 millimeters of mercury. DASH diet, which is a diet rich in fruits, vegetables, whole grains, fat, dairy products, and reduced saturated fat, also has a very significant impact with a potential to lower systolic blood pressure by as much as 11 millimeters of mercury. Similarly, dietary sodium intake decreasing with a goal of less than 1.5 grams per day translates into improvement in systolic blood pressure. Diet rich in potassium, exercise, aerobic, isometric, dynamic exercises all result in about 5 millimeters mercury decreasing your systolic blood pressure. Decreasing alcohol intake, so in men recommended to drink less than 2 drinks a day, and in women less than 1 drink per day, can have a significant impact on lowering the blood pressure by as much as 4 millimeters of mercury. Now, to understand the cardiovascular risk associated with uncontrolled hypertension, I share with you here a meta-analysis. So this was an analysis of 61 prospective observational studies of blood pressure and associated mortality. What this study showed is that there is absolute increase in risk for major cardiovascular events and death across the spectrum of age groups. So higher the systolic blood pressure, older an individual, higher is the risk of cardiovascular mortality. And this risk was equal for both men and women. So on the flip side of this, lowering blood pressure provides similar relative protection at all levels of baseline cardiovascular risk. Next slide, please. But progressively greater absolute risk reduction as the baseline risk increases. So these results support the use of a predicted baseline cardiovascular risk assessment, like I was sharing with you before, in terms of the ASCVD risk estimator, to inform the blood pressure lowering treatment decisions. Now, to summarize what we've talked about so far, accurate blood pressure measurement is very important for both the diagnosis and management of hypertension, and more intensive blood pressure therapy is recommended to reduce risk of cardiovascular events and mortality. We should employ strategies that are known to improve blood pressure control, both pharmacological and non-pharmacological, some of those that I talked about just now. So I thank you so much for your time, and perhaps we have a few minutes to take some questions.
Thanks so much, Dr. Gupta. What an incredibly informative presentation. Really appreciate it. So yes, in just a moment, we'll take some questions from the audience, but I had a question to kick us off, if that's okay.
Sure.
I think a number of us in primary care, I think, are starting to get a little confused by the seemingly conflicting guidelines coming out regarding goals for blood pressure. I was just wondering if you could share your approach to this with patients. How can we sort through all the conflict and come up with an easier approach?
Yeah, you're right, Dr. Hartman. I mean, there are many different societies with many different guidelines, and across the United States and amongst the specialties, and then across the globe, Canadian Society, European Society, they have their own target blood pressure numbers, which are different from the American College of Cardiology, American Heart Association. So I think to some extent, guidelines are just that. They are to inform us of the best practices, and we do have to individualize to some extent. But as a broad general principle, as I was sharing with you, once we are treating a patient for hypertension, a goal of 130/80 is universally acceptable in terms of their cardiovascular risk profile and in terms of their potential for end organ damage. So if there was one number I would take away safely from all these conversations, is about 130/80. And this sort of seems like a consensus document with 11 different organizations coming together. So
that's really helpful.
Question.
Thank you.
Yeah.
Yes. Let's see. So get a couple questions coming in. Is there an ideal time of day for blood pressure measurement for enhanced accuracy?
Yeah, that's a great question. So guidelines typically recommend measuring blood pressure first thing in the morning, last thing before you go to bed, for an average of about 15 to 20 readings over a period of 2 weeks to come up with sort of an average blood pressure. So I sometimes give my patients a blood pressure log and encourage them for 2 weeks to check their blood pressure twice a day. And we feel like that gives us enough of a good data to base treatment changes on. The other things that guidelines recommend is when you start a patient on blood pressure medication, studies have shown that if you follow them frequently for an initial period, so every 2 to 4 weeks until their blood pressure is controlled, then their long-term outcomes are far better than when their follow-ups are scheduled, say 3 or 6 months out. So, so those are, some of the best practices.
Okay, great. Really good question here. How comparable are blood pressure measurements when you look at devices in the office versus ones patients buy at stores? I know this comes up in my own practice often.
Yeah, it comes up in my practice too. And so one of the things I've encouraged patients to do, there is a website called validatebp.org that has a list of some of the validated blood pressure monitors that are available in the market. And then I also encourage patients to bring their blood pressure monitor to my office and check their blood pressure with their monitor and compare it with my manual monitor. And that sort of gives us an idea of how far off are we from baseline. For the most part, we find that a lot of the monitors available through standard pharmacies have a pretty comparable measurement. So I would encourage patients to take their monitors to the doctor's offices once in a year or so.
Mm-hmm. Compare them side by side.
Yeah.
What are your thoughts on scheduling medications at night or versus morning? Can you speak to kind of timing of antihypertensives?
Yeah, so most of the antihypertensives that are first line, for example, calcium channel blockers such as amlodipine, ACE inhibitors, or ARBs are typically once a day medication. And in those cases, we encourage patients to take them same time every day. And we essentially whatever is more convenient to you, morning versus night. In terms of diuretics, we typically encourage patients to take them in the morning so they don't have to deal with nocturnal awakening from diuresis. So diuretics typically in the morning, other medications any time of the day, but consistently the same time each day.
Okay, great. I actually had another question. I know there's some recent data looking at 2-drug therapy at lower doses versus monotherapy at maximum doses. I was wondering if you could share us what the evidence suggests is the preferred strategy there.
Yeah, thank you, Dr. Hartman. You have lots of great questions. So in terms of drug therapy, so there have been some side-by-side clinical trials looking at, maximizing the dose of a single drug. Now, of course, that is convenient to the patient. It's one pill to take and you just keep increasing the dose. But studies have shown that actually better blood pressure control is achieved when two drugs are used in lower doses together. It does a couple of things. First of all, when you use one drug and increase the dose to the maximum, the potential for side effects is much greater. When you use two drugs in lower doses, the potential for side effects is less. And studies have shown that better blood pressure control is achieved and long-term outcomes are better. So in general, even though patients' pill burden is a little bit higher, two-drug therapy is favored to a single drug agent. Also, combination pills are available. Now, there are some limited combinations, so it becomes a little inflexible after a point, but combination pills can help reduce some of the pill burden. Overall side effects are less with two drugs in lower doses.
As you mentioned in my little bio at the beginning, I love talking to my patients about lifestyle recommendations. It feels like it sort of gives the power back to the patient. And so regardless of starting an agent or not, obviously, counseling your patient on lifestyle modifications is important. Is there one lifestyle recommendation you find to be the most effective or where you get the most bang for your buck?
Yeah, I was sharing those numbers in my presentation. It seems like the DASH diet statistically and scientifically seems to have the most impact with an ability to reduce systolic blood pressure in double digits by as much as 11 millimeters of mercury. Weight loss, again, 1 kilo of weight loss can result in 1 millimeter of mercury reduction in blood pressure. So those are somewhat, easy aspirational goals for heart healthy lifestyle overall. They have more benefits than just lowering blood pressure. Other things such as consuming alcohol in moderate quantity and aerobic exercise. So I typically tell patients 30 minutes of brisk walking 5 days a week, aiming for about 150 minutes of brisk physical activity a week. Again, can lower the blood pressure about 5 to 10 millimeters of mercury. And for patients with low cardiovascular risk, that is actually the preferred first line recommendation. So really, I think as you hit upon it, giving the power back to the patients, giving them that opportunity to delay getting on medications for high blood pressure.
And so many other benefits to their health as well. So yes, great recommendation. This can be maybe our last question. Curious if you can remind us, if you don't mind, of the definition of malignant hypertension and accelerated hypertension. And maybe we'll close off with that one.
Yeah. So accelerated hypertension is defined as, sudden severe increase in blood pressure resulting in end organ damage. So you may have come across when people have sudden severe rupture of a blood vessel in their eye, for example. That would fall in the category of accelerated hypertension. Malignant hypertension is truly an emergency where the systolic blood pressure may go as high as 180 to 200, diastolics as high as 120 to 140. So that is truly a medical emergency. But yeah, those are conditions where you want to become suspicious about a secondary cause of hypertension. And once you deal with the acute situation, do a more thorough workup looking for secondary causes of high blood pressure.
Great, thank you so much. Unfortunately, that's all the time we have for this session, but really appreciate all of the knowledge you've imparted to us, Dr. Gupta.
Thank you, Dr.
Yeah, and also an invitation to the audience, keep the questions coming and we'll keep track of them for follow-up even after the session. So thanks again, Dr. Gupta, for joining us in this session. Well, it's now time for our second topic of the afternoon, racial disparities and their impact on high blood pressure management and specific barriers to health. We have a wonderful group of presenters joining us, so it's now my pleasure to introduce Dr. Brian Rickey, Leda Garside, and Lillian Navarro-Reynolds. Dr. Rickey is an associate professor of medicine at Oregon Health and Science University. He is currently the director of graduate medical education and the internal medicine program director for the newly accredited internal medicine residency program at OHSU Health Hillsborough Medical Center. He currently serves on the HMC Diversity, Equity, Inclusion Committee as well. Leda Garside is a bilingual, multicultural Latina professional. She works at OHSU Health Hillsborough Medical Center as well as Salud Services Clinical Services Manager and Cultural Liaison. Salud Services is an outreach program of the Tuality Healthcare Foundation, providing healthcare services, education, and patient navigation to vineyard workers and their families who live and work throughout the North Willamette Valley. Leda also currently serves on the HMC Diversity, Equity, Inclusion Committee. And Lillian Navarro-Reynolds has been a physician assistant for 16 years, practicing family medicine, endocrinology, and mobile health. She has practiced medicine and worked in PA education in multiple states throughout the US and the UK. Lillian is currently an assistant professor and the director of academic education for the OHSU Physician Assistant Program and a physician assistant with Salute Services, serving vineyard workers across Oregon. We will have time for questions at the end of their presentation, so be sure to ask away in the chat box, making sure again that you choose all panelists and attendees from the drop-down menu. All right, let's get started.
Well, thank you so much, Dr. Hardman, for the wonderful introduction. Three of us are looking forward to speaking with you today. And thanks to everyone who helped to organize this session and all of you for joining. Next slide, thank you. So just to kind of start with an overview of our section of the symposium tonight, I'll start by talking a bit about the disproportionate healthcare outcomes experienced among Latino or Latinx community. What are the underlying drivers of some of those healthcare disparities, including notably the impact of structural racism? After this, Leda and Lillian will move into more of a case-based approach to understanding those disparities and speaking about a patient that they've worked with for several years, and then talk about sort of some notes from the field and what we can do as a medical community to address some of these disparities experienced by this community. I want to start with an article, a relevant and current issue around COVID-19 among the Latinx population. This article is from 2020, so at the beginning of the pandemic, and it does feature, it's from the New York Times, it does feature an experience of Hillsborough. And it really does highlight a couple of experiences of this community that around COVID-19, that Latinos were 20 times more likely than other patients to screen positive for COVID-19. And 49% of Hispanics say that they or someone in their household has taken a pay cut or lost a job because of COVID-19. So this was sort of highlighting the impact of COVID-19. It really, this issue shines a light on a bigger issue that's been present for a long time, which is the healthcare disparities experienced by communities of color, like the Hispanic community in Hillsborough. So to kind of narrow in a bit on the impact of hypertension, so Dr. Gupta talked quite a bit about this. First, I want to highlight that the proportion of patients or people with hypertension among these two groups, Hispanic and Latino or non-Hispanic white. So 2018 data shows that they're actually pretty comparable in terms of the prevalence of hypertension, about 24% in each of those groups. But then if you look at blood pressure control, the Hispanic or Latino community has a much higher rate of blood pressure that is not under control. And as highlighted by Dr. Gupta, this has a significant mortality impact when we think about the long-term outcomes. But then the question is why? Why do we see things like this where certain communities of color are disproportionately affected? I just want to highlight one model. This is adapted from an article from Philbin in 2018, where this is a framework to explain why we see healthcare disparities in this population. I'll start on the left side of this diagram and just mention structural racism, and I'll define that in a little more detail on the next slide, but also to note that there are institutional and governmental policies. These are in combination structural forces that have downstream effects in terms of health outcomes. And these institutional government policies are things like licensing, labor laws, mortgages, housing, and they span multiple areas and again, disproportionately affect communities of color. The next slide, thank you. So there are many definitions of structural racism, and I think this one really highlights the issue well. So basically saying that societies foster racial discrimination. And of course that happens within healthcare as well. This happens via mutually reinforcing or inequitable systems. And those systems can be housing and education, employment, earnings, benefits, a number of areas that when those inequitable systems are in place, they then reinforce discriminatory beliefs, values, and the distribution of resources. Go back to this framework slide. That structural racism really does impact some downstream aspects of healthcare. So one is on stress. And so there's a good research to show that structural racism then leads to stress, which leads to worse healthcare outcomes and poor health. Also, it leads to inequitable access to healthcare services. And then the social determinants of health or material circumstances, all of which sort of come together to, again, lead to disproportionate impacts. On the next slide, I think many of you have probably seen different versions of this slide, but it's just important to highlight what are the social determinants of health. They span from economic instability to housing, to food insecurity, education, things that impact multiple areas of people's lives, and then again lead to worsened healthcare outcomes. So there are really two major sets of forces here. There's structural forces and there's social forces, both of which can impact folks to then lead to healthcare outcomes. So just to go into a couple of additional specifics and stats around the Latino community. So Latinos are less likely to have access to healthcare compared to non-Latino whites. Nearly 2/3 of undocumented Latino immigrants lack health insurance, because in our society it's very difficult to get adequate regular health insurance if you're undocumented. And then in general, Hispanics have the highest uninsured rate of any racial or ethnic group in the US. And as you of course know, insurance is tied to healthcare access and thus healthcare outcomes. We see this also in the distribution of the healthcare workforce. I'll just highlight Hillsborough in particular. It's about 23% Latino, and yet a small proportion of our healthcare providers are from this community. So just 5.7% of nurses and 6.3% of physicians. And this is in part because Latinos are underrepresented in many medical training pathways. And we'll talk a little bit more later on some of the ways we can mitigate this or improve this issue, but it is a significant problem throughout healthcare. Now I want to turn it over to Leda and Lillian to talk more specifically about a case of hypertension and the experience of migrant and seasonal farm workers in our community.
Thank you. Great to be here. I'm just going to talk briefly about our Salud program. And as Dr. Hartman already mentioned, we are an outreach program out of the Quality Healthcare Foundation. We serve agricultural workers throughout the North Willamette Valley here in Oregon, and we concentrate in vineyard workers and their families. Our services have multiple access points. We have mobile health services. We have services in the community, telehealth, appointments here at our home base here in Hillsborough. And we also do some home visits as needed, and also lots of case management. We promote wellness and prevention to our workers and family members. We're very fortunate that the entire team here is bilingual, bicultural. We are all Latinas as well, which is very unusual for a department, but we are 100%. And our funds, which is phenomenal, is our funds are all donated, and that allow us to do a lot of services and for these workers. And the other point that I want to point is our programs and the services is celebrating 30 years this year, which is phenomenal. Next slide, please. So I like to now talk briefly about the health challenges that migrant and seasonal farm workers encounter. These are essential workers that are the backbones of the agricultural industry and many other industries in our country, in our state. Agricultural workers come from a different background. Some only speak a native or indigenous language, so we have to be aware of that and always ask, not assume that everybody speaks Spanish. And also we know, and we see all the data, that diabetes and cardiovascular illness are prevalent and are directly linked to high blood pressure. And as clinicians, we must address and work closely with the patient and his or her family to monitor and manage. We are learning and gaining better understanding of the health issues facing agricultural workers by collecting data on chronic illnesses, their prevalence, and the impact on health outcomes. According to the National Center for Farm Workers' Health, more health research is needed to better serve the population and continue to improve best practices of care. Data also indicate that these are the most prevalent acute and chronic illnesses for Latino migrants and seasonal farm workers, with blood pressure on the top of the list. And in the last 2 years, as already mentioned, COVID-19 has made an incredible impact on this population. And we now know that the virus exacerbates any of these health conditions, in particular cardiovascular diseases. Next, please.
Thank you. So Dr. Ricky gave an overview of the prevalence of poorly controlled hypertension in our Latinx or Hispanic patients on a large scale. Leda was able to give an overview of the health of our agricultural workers. And I'd like to highlight a specific example to illustrate how these statistics and concepts come together to impact an individual patient. So the patient that we're talking about this evening is a gentleman who has actually been attending Salud Wellness Clinic since about 2007. And the Salud team has been really worrying about his blood pressure since about 2012. He has worked many jobs at the vineyards, generally working very long hours, and importantly has really little to no autonomy over his schedule. Seasonal vineyard work is really time sensitive, and he will stay until the work is done. He often works driving a tractor, which is important because his shifts can start at 5 a.m., meaning he gets up at 4 to get ready for work. And he's really concerned about staying alert during his long shifts. And what our team found after a little while is that in order to stay awake, he was drinking lots of caffeine, lots of sugary drinks, in order to stay alert. And so I'll talk a little bit later about some of the education that was done that he was very open to. Outside of work, he's a very active member of the community. He's a father, he's a husband, really enjoys playing sports with his kids. And over the time that the Salud team has been working with him, we've been really worried about his poorly controlled blood pressure since about 2012, with multiple referrals to primary care to urgent care for management. Next slide, please. So this is a snapshot of the time that we've seen this patient over. In the left-hand side, those are year dates. So we've been seeing him since May 2007, 1 to 2 times a year during wellness clinics for the most part. And off and on, he's had insurance. So as was mentioned earlier, one of the barriers to consistent care was whether or not he could be seen with primary care providers with insurance changes that made it really difficult for him to follow up oftentimes. Over the years, as you can see, there were multiple referrals, was able to maybe follow up a couple of times and then lost to care. And his numbers continued to increase to the point where they were incredibly worrisome over the last couple of years. The Salud team really worked with him, talking to him about diet, talking to him about educational recommendations, physical activity, weight loss, and he was very open to all of this. When I saw him over the last year, he was very proud to show decreases in his belt buckle notches and really wanted to ask lots of questions about diet and exercise recommendations. The Salud team eventually became much more involved in his care as the years went on. So from seeing him a couple of times a year at wellness clinics to really taking this on as a case management, as Leda mentioned earlier that we sometimes do, calling him, involving his family, and really figuring out what are the barriers to follow up and why was his blood pressure becoming so wildly out of control. Next slide. So over the last months, we've seen that his blood pressure actually came into very good control. He established care with a primary care provider. And at one of the follow-up wellness clinics, it was a little bit confusing. We had got his blood pressure. His blood pressure was very well controlled, but all of a sudden his blood sugars were off the charts. So we needed to figure out what was happening. Why was he lost to care? He was taking medications, he was seeing a provider, and all of a sudden screening sort of stopped and other care, kind of fell through the cracks. Next slide, please. So when we talked with him, what we found was that he had established care with a primary care provider. He had been taking his medications. He was diagnosed with obstructive sleep apnea and was using a CPAP machine. But unfortunately, because of his unpredictable schedule or his need to sometimes stay late at the site, he was late for one appointment. And the next appointment he missed, and he was charged a fee for missing that appointment. So from a clinic perspective, it would be easy to assume that he was non-compliant, that he maybe it was maybe frustrating that he couldn't show up or call or reschedule. But so there were a couple of issues in understanding the healthcare system, figuring out what schedule might work best for him. A lot of factors that he didn't have control over, and that when we could coordinate care with him, became a lot easier to work with. We found that also language was certainly a barrier. So this patient could be assumed to be fairly fluent in English. He definitely had a strong basic level of English, but was much more comfortable and much more likely to ask questions when he had a certified medical interpreter. So really important to make sure that although providers may speak some Spanish and the patient may speak some English, we don't know if if we can really build that rapport and get all of the questions asked and answered unless we're using a certified medical interpreter every time. And again, we found that he had low health literacy, not really understanding necessarily how the system works, what's an urgent care versus a primary care versus needing to go to an emergency department. And so all of those things he needed some help exploring and navigating. Next. Great. So what we found, again, that this patient, once we could take some time and talk with him, really open to education and engagement, especially with, as I said, a certified Spanish interpreter, more likely to ask more questions and get clarification. We involved his family. His wife is someone who does a lot of management of other things in his life. And so was someone that he could go to about what medications are for what time does he need to take them, and helping him to have kind of a safety net as far as staying on medications and making appointments. There was some education provided as far as the healthcare system and how to be successful in follow-up. And then also just finding out what are the barriers to attending appointments. I have the luxury when I work with Salud of having a pretty flexible schedule. He was late, sometimes an hour to appointments that were in person with me, but he was on time with telehealth visits. So as much as we could, doing telehealth follow-up, talking about going through blood sugars, going through a blood pressure log, talking about potential side effects of medication. He could step away from work for some time, or he could pull over if he was driving and have those visits, again, with an interpreter present, really contributed to success. Go ahead and next slide. I'm going to turn it back over to Dr. Ricky and Leda for more solutions.
Thanks, Lillian. I would really just highlight here what we can do as a healthcare community in really three specific ways. One is thinking about training. So we know that there is bias and discrimination that occurs in healthcare settings. And one of the ways to mitigate this is doing things like implicit bias training, employing culturally responsive care, and then anti-racism training as well. And one other area I would add here is bystander training. So there's just multiple ways that we can do training for healthcare providers in many different settings. The second way, and I highlighted this a little bit earlier, is that there is a disparity in the proportion of underrepresented minorities in medicine. And I think we really need to work on recruiting and retaining underrepresented minorities. And one of the ways of doing that is kind of creating holistic review processes when we look at candidates, but then also having mentorship throughout the medical training pathway. And then the third way, which is highlighted in a very good article by Ramirez just this year actually in JAMA, where we have to work on giving presence to Latino and other racial and ethnic minority groups in all facets of society, including in leadership positions, especially in medicine. I think I'll hand it over here to Leda.
Thank you. These are somewhat more suggestions about upstream approaches that we are, practicing and promoting and learning more. And the presentation just was done with this patient. We know that the challenges are many and they're real. And what these cases have demonstrated is that we need to have more of these upstream approaches to understand the patient and be an agent of change. We also know that people struggle to manage their care. So, so these steps that we are taking are a roadmap that our team takes to improve the health and the well-being of our patients. We know also that these are best practices of care and that we have to be flexible too in the delivery of the care of these patients. Next, please. We also know that for salute services and other outreach services, the aim is to promote early interventions and identify those early risk factors that we need to consult with each other, with providers, with other clinicians, with partners, community partners, with the patient themselves and the families, and to work in partnership to implement these interventions based in their healthcare needs. And our goal is to make a positive impact, the short and the long term. Next, please. And in essence, when we talk about, outreach services, the pledge is as clinicians is for us to recognize the value and the importance of providing culturally appropriate care and acquire basic knowledge to a specific culture. Latinos are the largest minority population in our service area, in our state, in our country. It's important for us to learn and to have a good grasp of the health practices of our patients and to develop trusting relationships. And I can tell you as a Latina nurse that I was born and raised in Costa Rica, I had to learn a lot about my Latino patients. I have to really take time to learn about the Mexican culture, about their healthcare needs, their practices, and all of that. So that's been very, very important to me and our team. And I highly recommend for all of us to take that as well, that approach. And for us is to continue to build a healthcare system that is accessible and that demonstrate great respect for the cultural beliefs and to meet the needs of our Latino patients. And I thank you for this.
Yeah, thank you so much. What an incredible conversation. Really appreciate your comments, Leda and Lillian and Dr. Ricky. I'd like to invite the audience to submit questions via the chat. I'm going to go ahead and start off with one. As someone who speaks a little Spanish, I went to medical school in San Diego and learned some medical Spanish there. I admit it's often tempting to try to save time and conduct an encounter with a Spanish-speaking patient by myself. Obviously, I know it's preferable to use an interpreter, but with the time pressures, 20-minute visits and things, it's tempting not to. I'm curious if any of you could comment on ways you found best to work with a certified interpreter in a way that's maybe more efficient.
Yeah, that's a great question. And I agree, it is tempting. I think there's a lot of benefit, though, to having some medical Spanish, because even in working with a translator, it helps you confirm and have an idea and follow the conversation even better. I think with technology, we're improving our access to interpreters. Phone interpretation is available. Video, I think, is much better when available because everybody can see each other and there's a lot that can happen in expression. But what I found is that, again, like I said, patients are much more open to asking questions and clarifying when there's someone who is totally fluent and can get the subtleties. So the slang is often important. There will be lots of food or medications that are used traditionally that I might not be familiar with, that oftentimes a translator is, or can really get clarification that makes sense. I've also found that wearing a mask really is another barrier to understanding, especially if my Spanish is not at the level of a medical translator.
Yeah, great points. Thank you, Lillian. All right, we've received a couple of chat questions. Leda, I think this one might be for you. I imagine it may be difficult to follow a patient that seasonally travels outside your care area for work. Is there much ability to coordinate care with other providers to ensure the patient's hypertension is continually monitored and treated, particularly when they're moving around?
Yes, what we do is that to connect the patient with a federal qualified health center or a community-based organization or clinic, and just to follow up with him or her on that aspect. We've been very fortunate to be able to do that, and we have a case that the person moved down to California, and we were able to send his records down to the clinic in California for follow-up care.
Right, so Salud sort of serving as the glue sort of between the different providers. Thank you. Here's another question. For the past 20 years or so, I feel we have more mixed couple marriages. For example, a non-Hispanic white having children with an African-American or Latina. How do you approach or assess their health, particularly as it relates to cardiovascular risk when it comes to family history in that setting?
Well, I'm happy to comment here. I think, and this may be a question, I don't know if Dr. Gupta is still here as well, but thinking about family history, cardiovascular risk. But I think to answer your question, which is it's a really good one, you have to think about what is that person's risk. So taking a family history and interpreting what their parents' background is, what their family history is, and sort of taking sort of an approach where you consider all those factors. And I think your question is one thing I want to highlight with it is that we really do want to individualize treatment. And though, we talked a lot about the experience of the Latinx community and what experiences they may have, it's a very diverse group and each individual is very different. So I think it's important to sort of individualize that your care of that person, recognizing their background, but also sort of knowing who they are and individually.
Yeah, I would
Thanks,
echo what Dr. Ricky has shared. In the cardiovascular world, when we think about the cardiovascular risk, we typically look at sex differences and age. So early coronary artery disease before the age of 45 in first-degree relatives is considered as an absolute risk. So is certain female-specific, gender-specific risk factors. How race interplays with that is more cultural, more social determinants of health. So some of the things that Dr. Ricky was highlighting in terms of how access to care and certain cultural beliefs put patients at a higher risk. So that's one of the things that we have to then cautiously weigh in mixed marriages in terms of what cultures have been adopted by the family and how is that lifestyle impacting the cardiovascular risk outside of the traditional risk factors, which are high blood pressure, diabetes, high cholesterol, smoking, sedentary lifestyle, family history of premature coronary artery disease, and sex-specific risk factors. So those are the ones that we account for all patients. And then how culture and race plays with it is more a lifestyle or experience, social determinants of health driven a risk. So I don't know if that helps answer.
Thank you both.
Thank you.
That's all the time we have for this session, but thank you all audience members for your questions, really wonderful questions. And thank you again to our speakers, Dr. Ricky, Leda, and Lily. Well, it's now time for our final presentation of the evening, Leveraging Care for Diverse Populations. It's my pleasure to introduce our speakers, Dr. Regina Cesniak and Dr. Edward Saito. Dr. Cesniak is an internal medicine physician with clinical interests in social medicine, care of the underserved, and transitions of care. She works clinically as both a primary care provider at the Virginia Garcia Memorial Health Center and a hospitalist at OHSU Health Hillsborough Medical Center, where she also serves as core faculty for the internal medicine residency program. Dr. Edward Saito earned his PharmD from Creighton University. In his current role as Associate Professor of Pharmacy Practice at Pacific University School of Pharmacy and clinical pharmacist with Virginia Garcia Memorial Health Center, he has established himself as the first clinical pharmacist on a team of providers with whom he collaboratively manages chronic diseases via collaborative practice agreements. Take it away, Dr. Cesniak and Dr. Saito.
Okay, Thank you so much, Dr. Hartman, and to all of the organizers of this wonderful symposium. I'm very happy to be here. This evening, I'm going to talk a little bit about, along with Dr. Saito, the team-based approach to hypertension management that we practice at Virginia Garcia Memorial Health Center. Next slide, please. So just a brief outline of the rest of the presentation. So we'll start with an introduction of Virginia Garcia and our team-based practice, move on to an overview of our clinical pharmacy services, which will be highlighted by Dr. Saito, and how we use those services to manage blood pressure, outcomes and challenges with that approach, a brief review of some of the literature supporting our approach, and then I'll finish with providing some of my perspective and feedback on my experience with the team-based approach. Next slide, please. So Virginia Garcia, Dr. Saito and I are very fortunate to work at this federally qualified health center. So FQHC means that we receive federal funding to provide care to patients that are medically underserved. And the story goes that the clinic was founded in the 70s after the death of a young girl named Virginia Garcia, when she wasn't able to access care to treat a simple wound infection. And this young girl was the daughter of seasonal migrant farm workers. So we have a close connection to the community that Salute serves as well. And we're very proud to serve that community. We've grown a lot since the 70s. We now have 6 freestanding primary care clinics serving Washington and Yamhill counties, along with several school-based health centers, dental clinics, a women's clinic. We've achieved Tier 5 patient-centered primary care home status, and our team-based approach is a big part of that status, and I'll talk about that in a moment. We have integrated behavioral and mental health services, which are also really important in terms of our chronic disease management. And we also are fortunate to have on-site pharmacies at most of our freestanding clinics with 340B status. For those who aren't familiar with 340B, it's a program that requires pharmaceutical manufacturers to sell medications at discounted prices to clinics like ours, so that we can, in turn, sell those medications to our patients at affordable prices. So it helps us provide access to meds. A bit about our patient population. So we're serving over 50,000 patients a year in Washington and Yamhill counties. We serve a primarily Latinx or Hispanic population, but also have a diversity of other racial and ethnic backgrounds represented in our population. And many of our patients are really suffering with a lack of material resources. So 60% are living at or below the federal poverty level. 35% of those patients are uninsured, and the majority of those who do have insurance are using Medicaid or Oregon Health Plan. As I said, we have our roots in the seasonal farm worker community, and that's still a large fraction of our patients. We have about 24% of our patients diagnosed with hypertension, and there's some recent data from 2019 showing that we achieve control as defined by less than 140/90 in about 3/4 of those patients. Next slide. So this is a graphic from the Agency for Healthcare Research and Quality that's showing the traditional model of primary care. And I think the main point of this slide is to show that in the traditional model, the provider is really at the center, and all of the patient's needs are sort of filtered through the provider, who then may delegate tasks to other team members or refer to a specialist. But as I think this graphic demonstrates well, the provider can become a sort of bottleneck to efficient care delivery in the traditional model. So we instead practice team-based care. So the next slide shows a graphic of that. So also from the Agency for Healthcare Research and Quality, this slide shows team-based care. So the primary care provider still is at the center of team-based care, but team members are empowered to take ownership of many of the tasks involved in chronic disease management. So for example, the clinical pharmacy service and our nursing staff are playing a big role in medication management and in point of care testing. in disease monitoring. We also have a behavioral health team, which helps a lot in terms of addressing barriers to adherence when those are related to behavioral issues. We have team assistants and patient care coordinators and medical assistants who are helping with more of the day-to-day administrative and practical work of care. Next slide. So to sort of summarize the case for collaborative practice, we're in a setting with a population with increasing medical complexity and more demands on the primary care providers. The collaborative care practice model really provides a solution for providing that care without causing burnout. And our focus on coordinated care is appreciated and in the sense that our payers are now sort of demanding it in their payment structures. Next slide. So a bit more about how the Virginia Garcia Medical Home looks in particular. So on the left, you'll see our team structure. So there are several core teams in each clinic, and each of those teams are made up of a few providers, a team nurse, a patient care coordinator who handles all the incoming messages and prior authorizations, ordering medical equipment. The team assistant handles our referrals, and the medical assistants help us carry out our visits. And each of those teams is supported as well by these embedded services that you'll see on the right. So clinical pharmacy, dental, mental health, behavioral health, all in service of the patient who is at the center of the model. Next slide. And now I'm going to hand it over to Dr. Saito to present a bit more about our clinical pharmacy service.
Thank you, Dr. Stesniak. And thank you to the planners of this important symposium. Thank you for the invitation to speak with you all this evening. I'm always excited to have the opportunity to share about the important role that clinical pharmacists play in integrated team-based primary care. And so for those, I thought I would start by just sharing a little bit about my own professional background for those who may not be familiar with working with a clinical pharmacist. And so I'm a clinical specialist in ambulatory care, board certified, and have undergone 2 years of postgraduate residency training following my PharmD degree. And in my role here in the clinic, I am primarily involved in providing collaborative management of chronic diseases through diagnosis-dependent prescriptive authority and collaborative practice agreements. I'll share a little bit more about what that means in a few slides. But essentially, I'm working here not in the pharmacy, but as part of our integrated member of our primary care team. I sit alongside our nurses and MAs and providers. So, that physical structure really enables that collaboration as we discuss patients on a day-to-day basis. And with the next slide, this shows the growth of our clinical pharmacy team over time from the beginnings in 2008 when we were able to hire our first clinical pharmacist at the Hillsborough location through a HRSA grant. And through partnerships with Pacific University School of Pharmacy and our CCO payers, recognizing the important role of clinical pharmacists, we've been able to grow this team over the years. The next slide here shows how we are distributed across all of our sites, and most of our primary care sites have 1 or 2 pharmacists, along with clinical pharmacist faculty from the School of Pharmacy and postgraduate residents as well. Next slide, please. So to describe a little bit more about what the role of the clinical pharmacist looks like, as I mentioned, primarily I'm involved in collaborative drug therapy management, which looks like referral-based chronic disease management for these specific disease states listed here. So for example, a patient sees their primary care provider and is diagnosed with hypertension. They are then have the opportunity to refer that patient to the clinical pharmacist for further management and follow-up. And we are able to do that either through in-person visits or telemedicine visits and be able to adjust medication therapy specific to that disease state. But really beyond focusing solely on that one particular disease state, we are able to take a holistic view of the patient's medication therapy and look for opportunities for optimization in all areas of their care, as well as be able to connect them to other resources that exist here in the clinic. And we are seeing our patients most often on an every 2 to 4 week basis. So I think that also presents a really important benefit where we are able to see those patients more frequently, as I think Dr. Gupta had mentioned earlier, that there's a lot of benefit to engaging our patients on a more frequent basis. Besides the direct patient care that we're providing there, we also are a drug information resource to our providers and medical staff. We provide comprehensive medication reviews and medication reconciliation, especially after patients are transitioning from an institutional setting back to primary care. Beyond our role in direct patient care, we also are involved across the organization in various committees and work groups, such as the Pharmacy and Therapeutics Committee, a work group to develop and revise standards of care that we publish for our providers, and also providing education, continuing education, and in-service presentations to our medical staff. So in these ways, we're able to influence prescribing practices across the health system beyond our role with with individual patients. Now you might be asking, why don't we have clinical pharmacists, in all of our primary care settings? And I would argue that and advocate that we should, because of the value that we provide. But unfortunately, the financial sustainability continues to present a significant challenge to the widespread integration of clinical pharmacists. And part of that is because at the national level, federal level, pharmacists are still not recognized as healthcare providers for the purpose of generating billable visits. And if we're not able to be financially reimbursed for the services that we're providing, it's difficult to expand that model. Now, fortunately for us here at Virginia Garcia, we started with an important HRSA grant that established our service. And as I mentioned, through partnerships with Pacific University and with our CCO payers, we've really been able to grow the service over the years. Notably, the savings that we are able to generate through the 340B pharmacy program is an important driver of that growth. And overall, focusing on the ability for the clinical pharmacy team to contribute to our performance on important quality metrics that determine value-based payments that we receive. And then finally, an important aspect of integration involves our outpatient pharmacies. And so on the next slide, I'd like to just describe a little bit more about some of the recent work that we have been doing in that space. And so in 2018, we instituted an outpatient pharmacy refill protocol, which enables our pharmacists to authorize refills of medications for specific chronic medications like antihypertensives. And in doing so, the pharmacists are able to look at the patient's chart, evaluate specific criteria like lab monitoring, whether the patient has engaged with their primary care provider in the last year. And if any of those things are missing, they have the opportunity to close those potential gaps in care. And all of this is striving to reduce workload burden on our primary care providers, but also to improve medication adherence and remove barriers to accessing medications for our patients. And we've seen some important success in doing this type of work. I'd also like to share some of our outcomes of the clinical pharmacy team on the next slide. And this is showing how a cohort of patients that were referred to the clinical pharmacist in Hillsborough were able to achieve greater percentage of time at their blood pressure goal, and also a greater reduction in their blood pressure overall. So this is showing how at baseline, the patients had an average systolic blood pressure of 148, and how that was reduced to an average blood pressure of 136 over this year of time. And 27% of those patients at baseline had achieved their blood pressure goal, compared to 65% after having worked with the clinical pharmacist. Next slide, please. Beyond the work that we do directly influencing clinical outcomes, I also wanted to share some important work that our clinical pharmacy residents are doing with regards to identifying potential gaps in equity with regards to how we screen and treat our patients. And so over the past year and a half, our clinical pharmacy residents have been researching potential differences in rates of screening for blood pressure across our population, and the potential differences in how we provide treatment or the medications that we select for our patients, and using multiple regression analysis to identify where there may be some specific contributing factors that explain those differences. Our preliminary results suggest that some factors such as race and sex, income, insurance type, and visit type may be specific variables that explain those differences. And I think this is an important first step to, identifying that there are these differences and starting to explain why those differences may exist. And then looking at institutional policies and perhaps unconscious biases amongst our providers and care teams that may be contributing to these equity gaps. Now, importantly, we've seen that in this COVID era, we have had a 52% decrease in screening for blood pressure. And a lot of that has to do with many of our patients just not coming in as frequently as they were before the pandemic. Next slide, please. But beyond the outcomes that we've been able to demonstrate here in our clinic, I also just wanted to share some of the published research that supports a collaborative practice model with pharmacists. So this first study here is showing a post hoc analysis of a randomized controlled study that compared usual care to collaborative physician and pharmacist care. And the box at the bottom shows that among those patients that were enrolled in the collaborative model for 24 months, they were able to demonstrate a higher percentage of time in therapeutic range or in target range for blood pressure. And I think this is an important outcome because it not only speaks to the number of patients that achieved a blood pressure goal, but also speaks to how well they were able to stay in that goal over time. I also think an important aspect of the study is that it mirrors a population similar to that we serve here at Virginia Garcia. And this greater population of time in therapeutic range was shown to persist across patients that had diabetes and chronic kidney disease, those from underrepresented minority groups, and those with a 12th grade education or less. Next slide, please. This next study shows a meta-analysis of randomized controlled trials, again, looking at comparing pharmacist intervention to usual care and demonstrating significantly greater reduction in both systolic and diastolic blood pressure for those patients that had pharmacist intervention. Importantly, there was a greater effect if that intervention was led by the pharmacist and if those visits were being conducted on a monthly basis. Next slide, please. So at this point, I'd like to turn it back over to Dr. Szczesniak to share more perspective from her perspective as a primary care provider.
Thank you, Dr. Saito. It's such interesting data that you're presenting. So I'm just going to share a few slides sharing my experience doing team-based care and specifically how with respect to management of hypertension. So just a few notes on the practical implementation of the care. So I want to point out that CPS is a huge part of that care, clinical pharmacy services, but we are also receiving a lot of support from our nurses, our medical assistants, and our behavioral health team to actively manage hypertension. And just to kind of walk you through what I'm thinking when I see a patient with very high blood pressure for the first time in clinic, or with uncontrolled blood pressure, how do I triage the follow-up plan? So depending upon the complexity of the patient and how well I know the patient, I try to decide based on that patient's need, which type of follow-up is going to be best for them. So for a very complex patient, I'll often want to have a few visits back with me to help build rapport and a therapeutic alliance and to reinforce education before handing over to clinical pharmacy service. For very straightforward patients, sometimes it's sufficient to just have a blood pressure check with the medical assistant in a few weeks. We have a lot of well-established but very complex patients with a lot of psychosocial needs who establish with clinical pharmacy service and stay on with them for some time. And then with the average complexity patients, often the nurses are chipping in for those cases. When we have patients that have behavioral or emotional barriers to adherence, we ask the behavioral health team to step in and to help us address those. So I'm very well supported in many ways when I'm sort of triaging my hypertension follow-up. Next slide, please. And then now I'm just going to sort of provide my insights on the challenges I've faced with this type of care, and then the following 2 slides will be the advantages. And I'll just say up front, I'm a huge fan of team-based care, and I think the advantages far outweigh the challenges. But to get those sort of out of the way, there are a few. I think the biggest one for me is that the follow-up plan, unfortunately, for an individual patient is more often determined by clinic resources than the patient's need. And that's, you know, a consequence of not having as many resources as we'd like. As I think Dr. Saito made a great case for it, the clinical pharmacy service is the ideal plan of care for probably most of our patients, but it's very costly for the clinic. And so we have to kind of reserve that resource for some of the more complicated cases. So that's one drawback. When we are using more of the nursing staff and the MA staff to follow up on a patient's blood pressure, that leads to a lot of administrative follow-up for me. So I may not be seeing the patient in clinic. I'm spending a lot of time in my in-basket following up the plan of care. So it does create somewhat of an administrative burden when I'm not able to use clinical pharmacy service because they operate a bit more independently. And then there's patient preference. There are some folks who really just want to minimize visits and they don't want to see too many different providers. It gets a bit confusing, who's who. And I think patients often in the setting of team-based care aren't sure who their provider is or what the exact role of the team member that they're speaking with carries. And then no-shows may be a bit more common with the pharmacy staff or the nursing staff than with the primary care provider. And it's also a bit more difficult for me as a primary care provider to sort of keep track of those who didn't show up and maybe make efforts to reach out to them and get them back in care. Next slide. But as I said before, I think the advantages far outweigh any challenges. And so I'll name on this slide a few of the more kind of practical, tangible benefits. And so first off, the cost to the patient is really huge. Our patients are charged a sliding scale to see me in clinic. And so hopefully it's affordable for them, but it's a free visit for clinical pharmacy service and for nursing. And for patients that are uninsured and working out in the camps, it means a lot to have no cost for the visit. And in addition, the flexibility that I'm afforded by having the option of many different follow-up routes and the availability of many of my team members as opposed to my own personal availability, it makes a follow-up plan possible when patients are working full-time, when patients have a lot of other responsibilities and barriers such as those that were discussed in the last presentation. So I discussed last slide about administrative burden that sometimes happens with team-based care, but in the case of clinical pharmacy service that often operates independently and with the automatic refill program, that's really relieving me of some of that administrative burden and in-basket work. So that's a big plus for me. And then again, patient preference. There are some patients who are more at ease with folks that are not wearing a white coat. And so the pharmacy service, the nursing staff, the behavioral health staff are able to interact with that patient and have them be more comfortable. I think a big, huge advantage to the team-based model is reinforcing patient education. It's easy to get confused about how to take your meds or what kind of changes you need to make in your life to manage your blood pressure. And so the patients get those messages from me at our initial visit, but also those messages are reinforced with each team member that interacts with the patient. And that's from the pharmacy service all the way to the medical assistants are really reinforcing patient education. And along the same vein, I think a huge advantage is that I uncover different barriers to adherence by utilizing my team members. So every team member has a different lens when they look at the patient, through which they look at the patient, and they can understand barriers to adherence perhaps in a different way than I can, especially if they can relate to the patient culturally. And so often patients will feel more comfortable disclosing lifestyle habits to other staff than they are to me, and it can help me understand what's getting in the way of my patient adhering to their medication regimen or their lifestyle change. And I think it has been mentioned several times through the symposium, the faster time to control is important. So we can have visits as frequently as every 2 weeks, or even more if we want, to get patients' blood pressure to control as fast as possible using all of the team members. And the next slide, please. So this slide is a bit more of the sort of holistic view of the advantages. So to speak, I think the prior presentation was a great one for understanding the barriers to adherence and the barriers to lifestyle change that many of our patients face. We're asking a lot of a patient who's diagnosed with hypertension when we ask them to change their lifestyle. So we tell them that they need to start taking medications every day, which may be a new practice, and to handle side effects that maybe that they haven't had to handle in the past. We ask them to change their diet, even though they may not have access to affordable, healthy foods. They may not have time to cook. We ask them to incorporate lifestyle changes like exercise, even though they may not have a safe place to execute that exercise. And so we're asking a lot of our patients, and in that sense, it takes a village to really take care of a patient, any patient with uncontrolled blood pressure, but especially a patient who's struggling without material resources and is struggling against the structural determinants that work against their health. So team-based care really affords a higher level of support for each patient. And I feel like we have a wide safety net for patients with barriers. So when a patient maybe doesn't show up for a visit with me, they may at some point interact with the nursing staff, with the clinical pharmacy staff, and we can kind of entice them back into care, and we can troubleshoot what led them to fall out of care in the first place. So I think our patients are really safer in this setting. And I'll just mention to close that as a primary care provider, I feel very supported in a team-based model. It reminds me that I'm not alone in caring for my patients. There's a great sense of camaraderie. And when the team-based dynamic is really healthy, it really feels like all of the team members are taking ownership of the patients and really are invested in reaching that control of their blood pressure. Next slide, please. And I think this is our concluding slide, but really just to sum up that we think collaborative team-based care affords a ton of benefits in many ways for patient satisfaction, access to care, medication adherence, reducing adverse events, reducing burnout. It's working very well for us at Virginia Garcia. And I'll just give a shout out to the clinical pharmacy services. I agree with Dr. Saito. If we could all have a pharmacist working next to us, we'd be have a much easier job in primary care.
Thank you so much. I can certainly speak to that as well. I couldn't do my job without my clinical pharmacist as well. So thanks for a wonderful presentation. Just a great example of how true team-based care can be a tremendous benefit to our patients, particularly those with hypertension. So thanks again to you both. Unfortunately, I don't think we have time for questions, but wanted to suggest to the audience members that they can submit questions even after the symposium. I think an email address should pop up in the chat any minute now, and you can send those questions to Lily, and we'll route them to the appropriate panelists. So thank you again to Dr. Sesniak and Dr. Saito for a wonderful presentation. And thanks to all of our presenters today. It's just been an incredible evening, a great discussion. So I'm now going to turn it back over to Lily Banning to close us out.
Thank you so much, Dr. Hardman, and thanks just for leading us through today's discussion. We really appreciate everyone joining our blood pressure symposium, and a special thanks to all of our presenters for the wonderful information they shared today. We will be sending a follow-up email with resources from today's discussion, as well as instructions on how to redeem CME credits. So on behalf of the American Heart Association and Hillsborough Medical Center, we'd love to thank you for attending. Please take care.